Okay, I think we're now ready to start the Q&A session. I think we have about 15 minutes or so of transmission time. I think we had 5 wonderful lectures. One of the questions that came up repeatedly was sort of what the key factors for success was in Korea, and I think it can be summarized as following. The first is actually the buy-in from the people of Korea regarding social distancing, the wearing of masks, and also understanding that there will be some issues with privacy when dealing with contact tracing. Second is the strategy of test and isolate. So the widespread testing that was done in Korea. It enabled the government to know precisely where they needed to target, and also early detection minimizes the spread of disease. And I think third, one of the reasons for success was early preparation, where the patients were matched with the appropriate level of admission beds. So whenever there's an outbreak, if the entire healthcare system breaks down, then there will be a big fatality rate. And also, there was an early designation of national strategic items for personal protective equipment and also masks. So, I mean, I don't want to be too optimistic, but up to now, I think the strategy that has been incorporated by the Korean government has worked so far. However, we can't be too optimistic. We may have a second big wave that we may have to encounter in the future. So let's start with some of the clinical features, the questions about the clinical features. So Dr. Che, I think some of the questions were, when can patients with confirmed COVID-19 infection can be discharged from the hospital?
In the perspective of the patient treatment, we can discharge the patient when the symptom was improved and there is no need to oxygen therapy. But in the perspective of public health control, we can discharge the patient when we make sure that this patient have no infectivity. But there was no way to test for the infectivity. So instead of that, we can use the real-time PCR assay. But I think it's very highly sensitive, but there are no other way to figure out what the patient has the infectivity or not. So in the real setting, we can discharge the patient when the patient had 2 consecutive PCR negative results.
Okay, so yeah, as you said, clinically, so we are able to discharge the patient when the patient has no dyspnea, has no fever, and is feeling clinically well. However, because of the risk of spreading the virus, that we want to be sure that the patient is not shedding the virus, so we wait for 2 consecutive RT-PCR negative results. I think one of the problems with that is that we are keeping the patients in the hospital for too long of a duration than necessary. And I think that's what we faced in the early phase of this fight with the disease. And that's why one of the policy changes that was made in Korea was to be able to send some of these clinically improved patients to the living and treatment support centers. So it's sort of a sort of a hospital environment where patients are isolated, but not in a hospital sort of admission, in a hospital admission bed. So I think that's one way to try to triage some of the milder patients to get them outside of the hospital so that the hospital beds are ready to treat the very severe patients. I think the second question is about treatment. It's about, please explain the risks and benefits of the use of hydroxychloroquine and even passive plasma therapy to tackle COVID infection.
It's very difficult to answer this question. For the hydrochloroquine, this drug showed many antiviral activity for many viruses in vitro assay, but from now until now, there is no evidence to clinically improved when we use this drug for many viruses, including influenza or other viruses. But so we have to wait the clinical trial data for the hydrochloroquine, and this drug has many side effects, so we have to caution to use this drug. And the passive plasma therapy is the old way to deal with the infectious disease, but also this therapy have no evidence in randomized control trial, but there are some experience including severe influenza cases and SARS or MERS, and in one meta-analysis including the influenza and SARS and MERS, and it shows some positive benefit for the meta-analysis. So I think we can try to this plasma therapy for severe patients.
Okay, while you're at explaining the clinical options that we have, can you talk about remdesivir and also Kaletra?
Yes. In vitro assay, the remdesivir, the new antiviral agent, originally developed for Ebola, showed highly active in vitro assay. So now our hospital also participate in clinical trial for remdesivir now, and I hope the result will be published maybe in May. So we are waiting for the result. And for the lopinavir and ritonavir, this drug also shows some antiviral effect in vitro assay, but unfortunately, one control trial conducted in China and published the last month in New England Journal of Medicine, but the result was negative. But hopefully, in some subgroup, when the drug was administered for the early phase of the patient before the symptom onset, before 12 days, and in the subgroup there is some marginal positive result. So I think when we try this antiviral drug in the early phase of the patient, maybe it will be helpful for the patient. But we have to wait some another clinical trial data.
Okay, hopefully the clinical trial comes out to be positive. What about another question was, what is the risk of reactivation of the virus or the reinfection risk? And what immunity remains after you catch the virus?
Actually, the real-time RT-PCR is very highly sensitive, and the problem of the PCR assay is we cannot distinguish the result from the dead virus genetic material or that is from the live virus. And from now on, there are some reports that when the patient who discharged from the isolation due to the two consecutive negative result and turned down positive for PCR assay, but I think that is the redetection, not reinfection for the genetic material. So, for the perspective of immunology, and I think the reinfection is not occurred for this coronavirus. And once some one study result from China using animal model, and they infect the animal the coronavirus, and 1 month later they rechallenged the coronavirus to the animal and sacrificed and showed the pathology, but there is no evidence of infection due to the rechallenge. So I think
So being tested again and getting a positive result versus having a reinfection clinically is different, is what you are saying. Okay, thank you. So if we can move to the first talk regarding the epidemiology, one of the questions was Korea was one of the first countries to implement mass testing. What % of those who tested positive were asymptomatic? And how many of these were children? I don't know if you can answer how many of those were children, but Dr. Kim.
Yeah, it's not easy to tell the exact proportion of asymptomatic patient among those with positive test result. One of the reasons is that in Korea, we did massive testing, especially for the Shincheonji religious sector members. We received the whole information of the members, and we reached out them and then tested all of them. So they are asymptomatic at the time of the testing. So it's not easy to tell the proportion of asymptomatic, but so at the time of the testing, they may be asymptomatic, but a while later, some of them manifest the symptom, but some of them maybe they will not show any symptom until end of their course, their clinical course. So it's not easy to know what kind of proportion of asymptomatic.
Okay.
Yes.
I think what's important from the epidemiologic data and also clinically is the fact that it's not actually the % of patients that are asymptomatic, but the fact that even though you are asymptomatic, you are still capable of spreading the disease. So I think that's a very important clinical feature of this virus. And because of that, without diligent social distancing, it will be almost near impossible to completely contain the disease because you don't really know whether you have it or not. And it's not like you have symptoms and then you're starting to shed the virus. There is asymptomatic patients that are actually shedding the virus. So I think that's one characteristics that we need to think about. Another question was, what methodology or procedures did you implement to control community spread?
Yeah, I think this is already talked from me and from the moderator. In Korea, to reduce the spread in the community, we try to detect early of the case, and then we detected the cases. We did contact tracing very aggressively. So I think per one case, more than 300 contact tracing was done. So, and then we urged them to stay at home for 2 weeks. And then we monitored whether they show the symptom or not. While we are monitoring them, if they show some symptoms, we tested again, and then we find out. So we can stop the spread from them, from close contact to other people. So that kind of testing and massive, aggressive contact tracing is the key in controlling the outbreak in Korea.
So you know that there is some controversy regarding whether this is a violation of personal privacy versus the public safety issue. So do you think, in your personal opinion, I know that you don't have a right answer for this, but in your personal opinion, do you think some of the draconian measures that were done in Wuhan or in some other European countries where there was a complete lockdown of the city, do you think that's a better method, or do you think this close tracing is a better method?
Yeah, the disease like COVID-19, which spread asymptomatic phase, the social distancing, including draconian lockdown, is the only way to control the outbreak. But the lockdown is public health, in the perspective of public health, it may be acceptable, but in the social perspective, it causes many side effects to the society. So Korea did not try such kind of lockdown. So instead of trying the lockdown, we applied the soft social distancing, including the contact tracing and the testing. So it may reveal some privacy issues, but after most experience, our society are more acceptable to such kind of approach by the public health authorities. But after this kind of control activity, we need to review our activities with regard to the privacy, whether there is some invasion of private issues, private right.
Yeah, I think Koreans are much more accepting of the contact tracing after our experience with MERS. I want to move on to Dr. Lee regarding the diagnostics. Question was, is there a cross-reaction of the COVID test to other viruses or bacteria? I think it was covered in one of the lectures, but if you can speak a little bit more about that.
Yeah, the molecular tests, there are lots of companies produce products. They have lots of products. I think the reagents depends on the result, but generally speaking, real-time PCR is very sensitive and highly specific because it uses 2 primers specific for the target sequence. In addition, there is one probe in the middle, so it can increase more specificity. So I think generally very specific.
Okay, thank you. And then maybe we just have maybe a couple of minutes left for our transmissions. So maybe a question for our final speaker, Dr. Kim. Can you tell us about your experience with contact tracing in hospital-acquired COVID-19 patients and healthcare workers? I don't know if there was any hospital-acquired infection at Samsung. I don't think there was, but regarding your workers at the hospital.
Sure. Fortunately, we haven't had one at our own institution, but other smaller hospitals have. And from experience from the MERS, the contact tracing in hospital transmission must be done very expeditiously, and also you need to really scrutinize. Even asking questions with all the staffs that are involved, not just the doctors and nurses and the patients, the caretakers, but also maybe the patient transports, house cleaning staff, everybody involved in the occurrence area. What I would like to caution is that when such events occur, people have mental and emotional trauma and may resent and have a lot of feelings of anger. So it's what I want to emphasize is the mental approach that you need to pass on the judgmental aspect, but keep it at a more empathetic and inquisitive, but not investigative attitudes when you perform the questionings.